Alright, I'm back, fellow learners. Okay, did you miss me? Okay, this is your mentor, Ray of Gapus Mentors. I'm a test preparations coach for more than 25 years already, and I'm focusing my efforts on helping nurses attain or achieve their great American dreams by passing the NCLEX RN. That's actually my favorite thing to do in this world. Been taking all sorts of nursing tests. I don't know why I have penchant for doing that. Okay, so welcome to QuickFix session 12. And before we begin, please do print the PDF files that contains the content of QuickFix session 11. Those who have already printed it, kindly browse your notes and make sure that you are on the right number of session. For those who have not gotten a copy of this, you need to register through the QuickFix link we sent out. If you got the link to this session from your friend, please do ask them to also send you the registration link so we can send you through email a copy of the slides we're having today. Okay, that's all for free. And for QuickFix session 12, I'm also giving out 5 sets of this again, the NCLEX 311 book and nursing reminder sheet to the 5 lucky participants who can answer my next question. Okay, the question is easy, you just have to listen to me. And the international title of this book is NCLEX RN in a Flash. It's actually available in Amazon, and in the Philippines the local version is NCLEX 311. It's entitled NCLEX 311 because it contains the 311 most common functional concepts that you need to know for the test. Okay, so here you have the functional concept, how to apply it, the rationale, and some key points. Okay, so those of you who may want to have a copy of this book, participate in a raffle. I'm giving out also PDF copies of this book, selected pages that you need to focus on if you're taking the test within the month. Okay, so here we go. Welcome to QuickFix session 11. This is your mentor Ray. I'm a test preparations coach for more than 25 years. We would still be dealing with the most requested concept of prioritizing and delegation. And join us in this mission. Our goal is to provide free NCLEX RN application and review to 100 nurses, and we're doing quite well so far. We have assisted several nurses already. Most of them actually passed the NCLEX. And for those of you who already passed the NCLEX, please don't unsubscribe from our YouTube channel. Pass it on to your friends and tell them to subscribe so that we could keep supporting the nurses. Okay, so to help us achieve this, I'm just asking you to do one noble thing. Just watch and finish the ads in our videos. That's all I want you to do, and thank you. So reminder, if you have questions and if you may want me to cover topics in my future videos, send me your questions through this email, mentor.raygapus@gmail.com. Once again, that's mentor.raygapus@gmail.com. So let's begin your QuickFix session 12 with an inspiration. This has always been a very inspiring session. Okay, this is when I was doing my face-to-face class. This is actually done in a stadium here in the Philippines. If you can just imagine, my company started with 3 students and 2 of them were apathetic when I do my lessons, so that when I crack a joke, only one is laughing with me, and when that one individual gets absent, I was laughing to myself. So this is how we started until we became the first nursing review center in the Philippines to be awarded Super Brands. Okay, that was in 2005. Okay, so we'd like also to start this with an inspirational greeting to Bin Arkam Lakbao from Ateneo de Zamboanga University. Wow, that's in the Mindanao area in the country. USRN for passing Illinois Board of Nursing last January 3, 2021. Congratulations, Bin Arkam Lakbao, USRN from Ateneo de Zamboanga University. Now remember, passing the NCLEX is about knowing what works for you. So if our session is working for you, engage. If it doesn't work for you, then you have to find a way so that you'll be able to discover what strategy, what methods will best work for you. So, what is the best way, therefore, to prepare for the NCLEX? What other best way but to use functional concepts or to discover what works for you? And some do not discover that functional concepts work for them until they engage in our session. So, we're going to have another QuickFix session in February, so you can ask your friends to join us. Okay, and we're going to put our registration link out there. So let's try answering a sample question. Which of the following postpartum clients should the nurse assess first? And if we're going to take a look at the options, 1, 25-year-old primipara who delivered a baby boy 3 hours ago after 12 hours of labor. 32-year-old multipara who delivered a baby girl 4 hours ago after 6 hours of labor. 28-year-old multipara who delivered twin babies 30 minutes ago after 7 hours of labor. 31-year-old primipara who delivered a baby girl 2 hours ago after 14 hours of labor. What if you have this kind of question in front of you in the computer? You would say, what would I need to look for to eliminate distractors? Would I need to focus on the age? Or is it on whether the client is a primipara or multipara? Or is it on the gender of the baby that they delivered? Or the number of the babies they delivered? Or is it on the number or duration of hours on how long ago they have delivered? Or is it the duration of hours of labor? So it's very difficult to analyze the question if you're not guided. This is where we need our superpower. Let's use a functional concept. Here's a functional concept. The greatest risk for postpartum hemorrhage, which could be life-threatening, postpartum hemorrhage occurs within the first hour after delivery. And take note that usually those who have twin deliveries are more at risk to uterine atony, which could lead to postpartum hemorrhage. Therefore, the client who delivered an hour ago or less than an hour ago should be the priority of the nurse, having that secret knowledge in mind. Okay, let's go back and answer the question. Go. Which of the following postpartum clients should the nurse assess first? Now we know what to look for. We will look for the postpartum client who just delivered an hour ago or less. This is 3 hours ago. This is 4 hours ago. This is 30 minutes ago, and you have twin babies, so they are at risk for uterine atony and postpartum hemorrhage. This is 2 hours ago. The best answer, option 3. See, that's what I'm trying to tell you guys. The NCLEX is easy if you know what to look for. To do that, you need to know your functional concepts. And once again, I'm giving free copies of my book that contains the 311 most common functional concepts. All you have to do is to give me an email to request your copy. So here's another question. Which of the following interventions is the highest priority of the nurse in a client with increased discharge of lochia rubra 25 minutes after delivering a baby? Of course, lochia rubra occurred several days after delivery, and it's the reddish discharge. Here, there's increased discharge. Now, the increase in the discharge could be brought about by what? Could be brought about by the failure of the uterus to contract accordingly after the delivery of the baby and the placenta. And when does that happen? A common cause of that would be a full bladder. So we need a functional concept as a guide. So a full bladder is the most common cause of uterine atony, which can lead to postpartum bleeding. Therefore, if a full bladder commonly causes uterine atony, it's very important for the nurse to prioritize assessing the bladder of the patient after the delivery. So if the bladder is full, okay, and the uterus is deviated to the left or to the right, that could mean that the full bladder is preventing the contraction of the uterus after the delivery of the baby and the placenta. So it could potentially lead to uterine atony. Now, let's go back to the question. Which of the following interventions the highest priority of the nurse in a client with increased discharge of lochia rubra 25 minutes after delivering a baby? And is it 1, notify the provider and obtain an order for medication? 2, administer oxytocin or pitocin? 3, palpate the client's bladder and fundus? 4, monitor the client's vital signs? And what did we say a while back? Our functional concept is a full bladder is the most common cause of uterine atony. So we need to prioritize assessing for the presence of the full bladder. And the answer would be 3. Palpate the client's bladder and fundus. Okay. Now, here's a question that deals with delegation to the unlicensed assistive personnel. Now, remember, when you are delegating to the unlicensed assistive personnel, the first focus should be on whether the procedure could be safely done by the unlicensed assistive personnel or not. If it could be safely done, then delegate it. If it cannot be safely done, then the RN should do it. And then make sure that the unlicensed assistive personnel have the proper education and training and competence. But all of this would be disrupted if the instructions are not properly communicated. And it's very important for the RN to supervise the implementation and then evaluate the implementation of the intervention, such that if you delegated the administration of oral medications, make sure that the medication has been taken by the client. Okay? So if you discover it to be at the client's bedside, so that means there is a problem in terms of monitoring and evaluation of the delegated task. Okay? So, here's the question. The registered nurse is preparing staff assignments for the day. Which of the following tasks can be assigned to the unlicensed assisted personnel? Select all that apply. Providing routine catheter care to a male client. That's a keyword. You have the word routine. You can delegate that. Okay, so remember, routine care, ADL, and standard and changing procedures can be delegated to the unlicensed assisted personnel. So let's implement. Providing routine catheter care to a male client, yes. Providing oral care every 3 to 4 hours, so that would tell you that this is routinely done. Okay, to a client with renal failure. Okay, so put a check. Reporting the amount and type of food consumed from the tray of a client with dementia. Okay, reported to the RN, yes. Okay, checking the skin of a client undergoing radiation therapy for redness. This is assessment. And this is a part of the nursing process. So it should be the RN doing this, not the unlicensed assistive personnel. Okay, so we put an X. And then notifying the physician for an abnormal laboratory findings. Remember, the unlicensed assistive personnel reports to the RN, not to the physician. It's the RN who reports to the physician. So we put an X. Okay, just to put everything in order. Remember, there's such a thing as what we call HMAs. These are health maintenance activities. And for health maintenance activities, for as long as these are done routinely, that's the context, routinely, then you can delegate administration of oral medications. Okay, now remember, if you put the meds, if you are serving as a home care and you put the meds, okay, in the patient's mouth, you yourself place it on the patient's mouth, it means you, the RN, administer the medication. But if you hand it over to your patient or the home care resident, put it on the patient's hand, and it's the patient who puts it inside his or her mouth, then we can say that the patient self-medicated or self-administered the medication. So there's a difference. So if you're the one who places it inside the mouth of the patient, then you are the one who administered it. But if you place it on the patient's hand and the patient is the one who placed it inside his mouth and took the medication, then the patient self-administered. Okay? So once again, oral administration, routine, oral administration of medication can be delegated, okay, as well as topical administration of medication, administration of insulin, administration of drugs through nebulizer and metered dose inhaler. Those can be delegated, okay. Now, other health maintenance activities like care of stage 1 pressure ulcer could be delegated to the unlicensed assisted personnel. Feeding and irrigation of feeding tubes in home care setting. For as long as the feeding tubes are permanent, and that's in home care setting, you can delegate that to the unlicensed assistive personnel. And administration of your oxygen, once again, in a home care setting, could actually be delegated to the unlicensed assistive personnel. Okay, so if you like what we are discussing and how you are learning from our session, please note that bell notification button, okay, and subscribe to our channel and share our channel to at least 3 of your friends, and I will pray for you that you're gonna shut down for the NCLEX RN for a minimum items of 60 and pass the NCLEX, okay? So that's one way of sharing God-given knowledge that we have been gifted with. So please do help me spread the news. A lot of our QuickFix participants have passed the NCLEX so far. I'm so excited that I'd like to turn them more into hundreds of thousands and even millions of nurses. Let that be my legacy. Okay? Okay, so let's move on. So for Christy, she sent us a note through our YouTube channel. I'm glad I found your videos because they're very precise. Thank you for your very reflective observation on the things that I need to know to pass the NCLEX exam with easy understanding. And I enjoy reading your book, The ABC of Passing the NCLEX RN. Great way to wrap up all the things we learned. Thank you, Dr. Gapos. Okay, I'm more comfortable being called Mentor Ray. In fact, even my students in the graduate school, I asked them to just call me simply Ray. Okay, we're all equal, we're all learners in this world, okay, such that, well, I was just ahead of you a few steps of the way. Okay, but that doesn't make me special at all. We're all the same. You, my fellow learners, could be the same as me. Okay, let this session be an inspiration. So for those of you who are new in our channel, please do check out our ECG or EKG pointers. We have also a comprehensive discussion of EKG and ECG that I formulated. It's a 3-step EKG interpretation method, okay? And then you have sample SATA question with rationale and mnemonics. And then you have NCLEX RN pointers on insulin. You can request the PDF copy of these files, of the slides, okay, by sending us a note through my email at mentor.raygapus@gmail.com. So let's begin our NCLEX Quick Fix session with the concept prioritizing and delegating related to assessing uterine contractions. Now, what a better way to start this discussion but with a sample question. So what if you have a one-liner? I call this a one-liner question on the NCLEX, like, which of the following clients should the nurse attend to first? Look, the phrase the nurse attend to first is asking you to prioritize. Okay, so is it 1, 29-year-old client in early labor with uterine contraction intensity of 30 millimeters mercury? 25-year-old in early labor with a uterine resting tone of 10 millimeters mercury. 27-year-old primipara with 3 uterine contractions within the last 5 minutes. And a 28-year-old multipara with irregular uterine contractions occurring every 10 to 15 minutes. Okay. When you're faced with this question, okay, you would ask yourself, what would I need to look for? Is it the age of the patient? Is it the stage of labor? Is it whether the client is a primi or a multipara? Or is it on the characteristic of the contractions as described in each options? So the key is to recall very, very important knowledge. Okay, so first, uterine contraction serves as the primary power of labor. Okay, so if we're going to apply that concept to the question, our answer would be number 3. I tell you why. Okay, because the normal duration of uterine contraction could range from 30 to 90 seconds depending on the stage of labor. The latent stage, it could be 30 to 45 seconds, okay? The frequency, it could last every 5 minutes. In the active phase of labor, it could be between 45 to 60 seconds duration, and it occurs every 3 to 5 minutes. And in the transitional stage of the first stage of labor, meaning you're now progressing to the second stage of labor, the duration of contractions could be from 60 to 90 seconds, and it could last, or the frequency could actually occur every 30 seconds to 2 minutes, which means as you progress through the labor, the duration of contraction increases and the frequency of its occurrence decreases. So which simply means that a client who is having uterine contractions whose duration is more than the normal, which is from 30 to 90 seconds within the first stage of labor, could be at risk for uterine hyperstimulation. So uterine hyperstimulation. Okay, so what does that tell us? We need to compute why number 3 is our answer. So how many seconds do we have per minute? So it's 60 seconds. Okay, so how many seconds do we have in 5 minutes? So 60 seconds times 5 minutes, that's 300 seconds. Okay, how many contractions did the patient have in 300 seconds? 3. So we divide 300 divided by 3. The duration of contraction is 100 seconds. Now, the normal duration of contraction we had a while back is 30 to 90. 100 seconds is simply above what is expected as normal. So the patient is at risk for uterine hyperstimulation. We need to assess if the client has taken an herbal remedy. Okay, we need to assess if the patient has taken an herbal remedy like blue cohosh. If the patient, usually it could potentially increase the duration of uterine contraction. So what is important therefore is to monitor uterine contractions during labor, and this is done through palpation and by electronic monitoring. Okay, to palpate fundus for contractions, place the pads of the fingers on the fundus, and assessment of uterine contractions includes frequency, duration, intensity, and uterine resting tone. Now, how do you remember all of this? Okay, sometimes the definition of frequency, interval, duration could interchange when you're stressed and anxious and sitting in front of your computer, taking the NCLEX, working your ass out. So what do we do? Now, let me actually make that easy for you. There are 3 phases of uterine contraction, namely the increment or the building up, the acme or the peak, and the decrement or the letting down. Okay? So the distance from the increment of one contraction to the decrement of the same contraction could be the duration. Therefore, to understand the definition of duration, interval, and frequency, we need to draw 2 uterine contractions. Okay, so assessment of contractions may include assessing the following. Okay, and we label them A, the increment of the first contraction, B, the decrement of the first contraction, C, the increment of the second contraction, and D, the decrement of the second contraction. Now, if we identify the distance from A to B, meaning the increment and the decrement of the same contraction, this is what we label as the duration of contractions. And what did we say a while back? The normal is 30 to 90 seconds depending on the phase of the first stage of labor. Okay, in the latent phase, it could be an average of 30 to 45 seconds. In the active phase, 45 to 60 seconds. And in the transitional phase, 60 to 90 seconds. Okay, now what about if we have the distance between B and C, the decrement of the first contraction to the increment of the first? Okay, this is what we term your interval. Okay, and last but not the least, the distance between A to C, or from the increment of the first contraction to the increment of the second contraction, is what we term frequency. So if you cannot memorize your terminologies, just visualize it using what we have drawn. So the distance from A to B, duration. From this, the distance from B to C, interval. The distance from A to C would be your frequency. And then to initiate labor, uterine contraction should reach an intensity of 30 millimeters mercury. So this is just the intensity of 30 millimeters mercury is related to the onset of your uterine contractions. During active labor, uterine contractions reach an intensity of 50 to 80 millimeters mercury. So 30 millimeters mercury could just mean labor is beginning. Okay, now during active labor, it could go up to 50 to 80 millimeters mercury. Uterine resting tone is normally between 5 to 10 millimeters mercury in early labor and between 12 to 18 during active labor. Okay, so in the care of the pregnant client, the unlicensed assistive personnel can assist in activities of daily living and gather data such as intake and output as well as vital signs. So let's try answering a sample question related to the concept of delegation. Which of the following interventions can the registered nurse delegate to the unlicensed assistive personnel when providing care to a pregnant client in labor? Now remember, any task that requires judgment of the registered nurse should not be delegated. So management of the second stage of labor. The second stage of labor would be the stage of the delivery of the baby. Okay? Progresses from full cervical dilatation to the delivery of the baby. So you cannot delegate that. It should be the RN who is attending to the client. Assigning an Apgar score, that's the role of the RN because it requires interpretation of data. Monitoring of the fetal heart rate for deceleration. So this is not routine monitoring. This is a monitoring for fetal heart rate for deceleration. Remember, late deceleration indicates placental insufficiency. Variable deceleration indicates cord compression. And both late and variable deceleration could be present in clients who was having fetal distress. Okay? Your early deceleration is not reportable because it is expected, because it's due to fetal head compression. You will need to implement the administration of oxygenation and positioning the client to the left lateral recumbent position if the client is having late and variable deceleration. So monitoring the fetal heart rate for deceleration is not for the unlicensed assistive personnel. We put an X. Assessment of the client's response to oxytocin infusion. Once again, that's an assessment. That's the role of the RN. While feeding the client during postpartum period, yes, the unlicensed assistive personnel could do that. Obtaining routine vital signs, you have the keyword there, routine, yes, the UAP could do that. Bathing the client before discharge, yes, the UAP could do that. Okay, now let's move on to hearing impairment. Okay, am I impairing your ability to hear already? Okay, no, because I'm just trying to speak using my normal tone and pitch of voice. Okay, so when we are speaking normally, this is approximately 60 decibels. Okay, now hearing impairment could result when you are exposed to noise that is above 70 decibels. Above 70 decibels. And if you are exposed for a longer period of time, like if you're working as a ground crew in the airport where the planes are, moving and they're making sounds more than 70 decibels, then that could increase your risk for hearing impairment. Now, let's proceed. The best way to protect one's hearing is to avoid exposure to very loud noise or limit the amount of time of exposure to loud noise. In young people, the most common cause of hearing loss is otosclerosis, while for older people, it is presbycusis. Now, in otosclerosis, you have a hardening of the bones, okay, the incus, the malleus, and the stapes, okay, and prevents the conduction of sound from the external environment to the ear to the interpretation to the brain. So which simply means that when you have otosclerosis, the patient may have impaired hearing. Now for older people, it's presbycusis. Sorry for the absence of the S, it's supposed to be P-R-E-S, presbycusis. Sorry for that, okay? So inability to hear high-pitched voice, such that for elderly patients, it's very important that we speak to them in the normal tone of voice, okay? So when there is hearing loss, always remember, we need to classify whether it's conductive or sensory neural. Now, this is important because if you are given an item that you will be asked to select all that apply, then you need to know what type of hearing loss occurs. It's not just knowing that there's hearing loss. You have to know which type. Conductive hearing loss is due to blocked sound conduction, and it affects the ear canal or the middle ear. Okay, so from the ear canal to the middle ear, your patient will have conductive hearing loss. Sensory neural hearing loss is a problem with the nerve for hearing. Okay, so cranial nerve 8, your vestibulocochlear nerve. Okay, since it's the nerve that is affected, then it affects the inner ear. It's usually permanent. So once again, conductive affects the outer to the middle ear. Sensory neural affects the inner ear. Now, what conditions could actually lead to conductive hearing loss? Okay, so ruptured eardrum, otitis externa, and otosclerosis. Okay, so if the patient has otosclerosis, what type of hearing loss occurs? The answer, conductive hearing loss. However, If a patient has Meniere's disease, okay, Meniere's disease actually occurs as an imbalance in the endolymphatic fluids in the inner ear. Always remember, otosclerosis is a problem in the middle ear. Meniere's disease is a problem in the inner ear. Okay, another way to differentiate it, otosclerosis causes conductive hearing loss. Meniere's disease causes sensorineural hearing loss, such that the triad symptoms of Meniere's would be tinnitus, vertigo, and sensorineural hearing loss. Okay, now presbycusis, which occurs in the elderly, causes sensorineural hearing loss. Okay, sensorineural hearing loss, which is usually permanent, also occurs when a patient gets infected with measles, mumps, meningitis. Now, that's why if you'll be asked on the test, to whom should you refer a client who had bacterial meningitis? Then refer the client to an audiologist. They need evaluation of their ability to hear, because bacterial meningitis could lead to permanent sensorineural hearing loss. Okay, this could also be associated, okay, with head injury, shingles, intake of aminoglycosides. Remember, your aminoglycosides are ototoxic, so it affects cranial nerve 8, neurotoxic, and nephrotoxic. Okay, so it's also exerting its adverse effects on the kidney. So it's important that your patients taking your gentamicin should be told that there's a chance that they could develop sensorineural hearing loss. It's also important that when you have gentamicin, you have to check the peak and true levels. The peak levels is best checked after the third and the fourth dose, usually within 30 minutes to 1 hour if the medication is given per IV. Okay, and then the true levels, meaning the lowest level of the drug, could be checked, okay, 30 minutes to 1 hour before the next dose of your aminoglycoside, like your gentamicin. Okay, now take note also that for elderly clients, your gentamicin should be given carefully, as they could damage the kidney. So if an elderly client has taken gentamicin, develops oliguria, then they could be suffering from nephrotoxicity associated with gentamicin. Acoustic neuroma is tumor of cranial nerve 8. Okay, and take note, acoustic neuroma could result to permanent hearing loss. And the kind of hearing loss that develops in acoustic neuroma would be sensorineural. Now, what if you have a select all that apply type of question, like sensorineural hearing loss occurs in which of the following conditions? Say, presbycusis, put a check, yes. Meniere's disease, yes. Acoustic neuroma, yes. Otosclerosis, no. That's conductive. Otitis externa, no. That's conductive. Okay? That's how you should study and reflect on this concept. So bone-anchored hearing aid and contralateral routing of signal hearing aids pipe the sounds from the bad ear to the good ear. So these are types of hearing aids in which you place it on both the good and the bad ear, and then whatever stimulation that it receives from the bad ear, it pipes the sound to the good ear for interpretation. Okay, so that's what we call your contralateral routing of signal hearing aids. Okay, now let's try answering a sample question. Which of the following interventions the highest priority, that's the magic phrase again, of the nurse when providing care to the client with impaired hearing ability? You have the keyword impaired hearing ability. Over enunciate words to promote understanding. I don't think that would help. Speak loudly while repeating words over and over. This would not help. Minimize environmental noise. Okay, we can consider. Provide longer period of time for the client to provide an answer to questions asked. Now, this could be associated with clients with aphasia. Okay, therefore, the best answer is number 3. Minimize environmental noise. Now, in the care of client with hearing impairment, the unlicensed assisted personnel should gain the client's attention and inform the client of your presence, face the client, ensure sufficient light, speak in a normal tone of voice, avoid over-enunciating words, use short sentences and simple words, minimize background noise, speak to the better ear, use communication board or hand gesture or sign language, repeat or rephrase statements as needed using different words to vary pitch. Okay, so which of the following interventions can the registered nurse delegate to the unlicensed assisted personnel? Select all that apply. Using communication board while interacting with the client, we put a check. Minimizing background noise in the client's room, we put a check. Ensuring sufficient light during interaction, put a check. Formulating a nursing diagnosis, that's part of the nursing process. That's the job of the RN. And determining the outcomes of the interventions that were implemented is the job of the RN. Okay? So in caring for a client with hearing aid, the nurse should discuss and demonstrate how to care for the hearing aid. Now, what are the things or the issues that we need to tell our patient on how to take care of their hearing aid? First, we instruct them to avoid heat and moist, and then avoid using hairspray while the hearing aids are in place. And then when debris are present, we can help them by telling them that they have to remove it with a soft brush or dry cloth or even a toothpick. Remove the debris, and then remove the ear mold from the hook, and then remove earwax with bendable wire, or you can use air blower when earwax attaches to the hearing aid. Okay, then demonstrate how to insert and remove the batteries. This is very, very important. Now, this depends on the type of hearing aid that the patient uses, but what's important is they know where to check for the batteries, whether it's properly inserted or not, and then demonstrate how to insert and remove the hearing aid. Okay, so here are the different types of hearing aid. This is labeled as traditional hearing aids. Okay, pay particular attention on how the ear mold is inserted. This is the ear that's inserted. Okay, this one goes to the back of the ear. This is the one that's inserted into the ear. This is at the back of the ear. Some of these have this in their glasses attached. Okay, so it becomes less prominent. Okay, this one goes into the ear. Okay, but there are also those people who are so creative that they have this kind of hearing aid. Well, for me, there's a safety issue here, because if one of these gets detached and then it goes inside the ear, I don't know if that would still help them out. But for any confidence or good feelings that they have because of the aesthetics of these kinds of hearing aid, may not compensate to the danger that it poses to the client. So even if it looks good, if it's dangerous, I don't think we have to do it. But what can you say about, this has become viral in my country. Those who had their face shields started with jewels like this. Okay, isn't this fabulous? But at least this thing, if ever it gets detached, it doesn't pose a great danger on our end, because it's away from whatever orifices that we have. Unlike the hearing aid, when anyone that gets detached could actually get inside the ear canal. Okay, and it poses a danger. Okay, so now let's move on to the next concept. Let's talk about prioritizing and delegation issues in clients with wandering and confusion. Are you learning, class? I hope so. So let's move on. Anyone who is ambulatory and with memory problems is at risk for wandering. And wandering usually occurs when patients have dementia, usually of the Alzheimer's type. Now, that's the reason why sometimes patients with Alzheimer's disease are not allowed to wear clothing that they use when they get out of the house while they are inside a home facility. Why? Because if you allow them to wear like jackets or nice shirts or nice pants, and then if you allow them to wear shoes, they would think that they should be going somewhere else, and that starts them to wander. So it's very important that they have to wear house clothes while they are in a facility. You don't allow them to wear shoes, you allow them to wear slippers to remind them that they are not supposed to go out. Otherwise, it poses a problem. So care needs of the client with cognitive impairment, those with wandering, include the 3 C's. Communication needs, because sometimes they have this condition in which they repeatedly say words without meanings. Okay, they have perseveration. Okay, caution, which means promote their safety, and comfort. So in the care of the client with wandering and confusion, the RN plans for daily activities, which means you have to provide them structured environment, implements activities at the times during which wandering may occur, then refrains from correcting the client and instead use exploration and validation techniques. When I say validation techniques, this would require the nurse or the unlicensed assistive personnel, the RN, to reorient the client frequently. Okay, that's validation technique of communication. Then place locks out of line of sight. So don't show them where the locks are. Okay, because they may have the tendency to try to open the doors or the access to the exit. Then supervises the client and keeps car keys out of sight. Okay, because they have the tendency to wander. They may be getting the car keys and then drive the car, then you lose them. Okay, so a structured environment means you have to have prepared activities that are scheduled for the patient, and you have to follow the schedules. Okay, so let's try answering a sample question. Which of the following interventions is the highest priority of the nurse when providing care to a client with dementia who frequently wanders at night? Okay, is it 1, leave the client alone once he goes inside his bedroom? I don't think this is a good option. Show the client that doors have been locked. What did we say? We don't show them this. Then turn all lights off, including night light, to remind the client that it is time to sleep. Well, this would pose a danger, because if the patient wakes up at night and it's very dark, that could further worsen the disorientation. Then provide a structured set of activities in the late afternoon and evening. This will help the patient anticipate and develop a routine for sleeping time. So the best answer would be number 4. Okay, so in the care of a client with wandering and confusion, the unlicensed assistive personnel should provide simple directions, assist in activities of daily living, and reports to the RN any of the following: confusion, change in the ability to communicate, weakness, paralysis or tremors, seizures, and difficulty swallowing or dysphagia. So in the care of the cognitively impaired client, the unlicensed assistive personnel should face the client and speak clearly, call the client by name and introduce yourself, orient the client to reality, keep sentences direct and simple, explain what you intend to do beforehand, then allow enough time for the client to respond, be mindful of the client's need for personal space, reduce environmental stimulation, do not argue with the client, and acknowledge the client's concerns and feelings, and provide diversional activities and use reminiscing techniques like asking the client to bring in old pictures and ask them to talk about the pictures. This will help them establish new memorable things that they could potentially they could use to potentially remember the past. Okay, you allow them to reminisce because this would lessen their sense of isolation. Here we go. Let's answer a question. Which of the following interventions can the registered nurse delegate to the unlicensed assistive personnel when providing care to a client who is confused and frequently wanders at night? Playing familiar gentle music in the evening? Yes, this will help promote relaxation. Keeping a night light on? Yes, to promote safety. Providing relaxing diversional activities? Yes, to decrease stress. Limiting the serving of coffee to the morning hours? Yes, that would promote sleep. And evaluating the effects of the limited TV viewing time to the client's sleeping pattern. This is evaluation. This is a part of the nursing process that should not be delegated to the unlicensed assistive personnel. Okay, now let's talk about this drug, Theophylline. Now, how is Theophylline used? How is its use different from cromolyn? Okay, so cromolyn is used for the prevention of asthmatic attack. Theophylline is usually used as a treatment. Okay, so your cromolyn may no longer be effective when the client is already having an asthmatic attack, because cromolyn is used for prevention of asthma attacks, whereas your Theophylline could still be effective even if the client has already an asthma attack, because it's used as a treatment for the asthma. Okay, so what is Theophylline? Let's make use of our framework, the CHECK framework. Remember, CHECK. C, classification. E, how will you know that it's effective? H, how will you know that it's effective? E, exactly what time do you give it? C, client teaching tips. And K, keys to giving it safely. Using that framework, let's try to recall. Okay, so the classification: Theophylline is a bronchodilator used in asthma and COPD to prevent wheezing and shortness of breath. So how will you know that it's effective? You have ease of breathing. Exactly what time do you give it? Best taken in the morning to prevent insomnia. Client teaching tips: you have to instruct the client to use it regularly, avoid smoking while on the drug, and instruct the client about keys to giving it safely. Focus on the signs of toxicity, and this includes nausea, vomiting, agitation, apical pulse above 200 beats per minute, which simply means could potentially lead to tachycardia and arrhythmias, confusion, dizziness, and seizures. But the common ones are this: severe nausea and vomiting. Okay, and then the therapeutic blood levels: 5 to 15 micrograms per ml for adults, 5 to 10 micrograms per ml for children and neonates, and then levels greater than 20 micrograms per ml are considered toxic. Now, using the knowledge we just learned, let's try to answer a sample question. So, a client who is taking Theophylline complains of the following signs and symptoms. Which one should the nurse consider as a priority for evaluation? Here's the magic word again, priority. What did we say a while back? If a client is taking Theophylline, focus on the signs of toxicity: nausea, vomiting, agitation, apical pulse above 200 beats per minute, confusion, dizziness, and seizures. I told you about the most common ones, so focus on that. The answer definitely would be nausea. Remember, your Theophylline causes tachycardia, not bradycardia. Okay, so the others are side effects. Okay, now let's talk about dehydration. Now, suppose you are given a situation, a scenario in which you have several patients all having dehydration. Which will you attend to first? So, who should be your priority? What are you going to look for? Will you need to focus on the degree of dehydration? Will you need to focus on the age of the client? This is what we intend to answer as we discuss prioritizing and delegation concepts related to dehydration. Okay, let's begin. Okay, can you get dehydrated from crying as hard as this? Well, let's create a story. What could have caused the crying? Could this could this person be someone who just broke off with a girlfriend, or someone who lost a loved one, or someone who lost a savings due to a scam, someone who lost a car? Okay, what would make you cry like this? You cry a river. For me, if you look at things, no matter how bad it is, as directional, so it's a way for the universe to give you a sense of direction, you'll never cry a river like this. If you see the positive side of things, sometimes what seemed to be a negative thing that happens, eventually you'd say, I'm glad that happened, because you were redirected to the right direction. That is the essence of our interpretation and how it affects us. So if we choose to look at things as directional, we'll never be unhappy. We will always be thankful that these things are happening. Okay? So always remember, if you pass the NCLEX the first time you took it, then you are called upon to serve immediately. If not, there could be some other reasons which you may not be able to understand at this point. But I tell you, if you click the bell notification button, and if you subscribe our channel and share it to at least 3 of your friends, we're going to pray for you, going to shut down the NCLEX at the minimum item of 60, number of items of 60, and pass the test. I promise you that. And you're not going to cry a river like this. Okay? So, here's a functional concept. Obtaining the body weight is the most objective way of monitoring body fluids. Why? Because the body weight represents the percentage of our body that is very dependent on the amount of fluids that we have. So remember, dehydration is more severe in young clients, and the percentage of body water in the human body decreases with age, such that the effects of dehydration would be more severe in young clients. So the percentage of body water in the human body is objectively reflected in the body weight. Look at this. The fetus could be 100%. The body weight is dependent on water. The baby at birth, okay, it's 80%. The body weight is 80% dependent on the amount of water they have. Normal adult, 70%. Look, the elderly person, 50%. So, if you have a baby who is dehydrated, whose body weight, whose 80% of body weight depends on the amount of water, they're going to have more severe dehydration than the elderly whose body weight depends on 50% of water in the body. So, which simply means between the elderly and the neonate could be more at risk to the complications of severe dehydration. So therefore, if we are being asked to choose which one should we prioritize, we need to prioritize the neonate or the baby. Okay? So let's try answering a sample question. Which of the following clients should the nurse attend to first? You have 80 years old with severe diarrhea. Well, they could be dehydrated. But look, 80 years old, the elderly. 2-week-old baby with no tears while crying. Some would mistake this as a form of a sign of dehydration, but hey, the tears don't come out until the baby is 6 to 8 weeks. So it's normal that the baby cries, okay, at 2 weeks with no tears, because the tears would come out at 6 to 8 weeks. So if it is a baby who is less than 6 weeks who's crying with no tears, that's normal. But if it's an adult who is crying with no tears, they're just making up. Okay, they just need your attention. They're just seeking attention. Okay, so 8-month-old baby with 5 episodes of watery stools. You have here a young client, okay, whose 80% of body weight would be dependent on the amount of water in the body. And 20-year-old with weight loss of 1 kilogram in 1 week. This could be within the normal range, but that's 2.2 pounds. Again, look at the age. So dehydration is more severe in younger clients. So the answer would be number 3. Okay, now in relation to the body fluids, it's also very important that you have to have a knowledge of the normal serum albumin. Now, what is the function of your albumin? Your albumin actually helps, okay, in maintaining your colloid osmotic pressure. So your colloid osmotic pressure is the pressure that draws fluid intravascularly or within the cells. Okay, so the normal serum albumin is 3.5 to 5.0 grams per deciliter, but some literatures would say 3.4 to 5.4 grams per deciliter, or 34 to 54 grams per liter. Okay, so what you have to remember is that a high albumin indicates dehydration. So if your albumin is higher than 5.0, it could mean that the patient is having dehydration or severe diarrhea. And a low albumin could indicate that the kidneys are unable to retain protein, such as in the case of nephrotic syndrome. So in which case, the client is going to have edema because your colloid osmotic pressure is low. So in a patient, therefore, with low serum albumin, and edema could develop, so what would be your priority intervention? Frequently turn the patient, because an edematous skin is prone to pressure sore formation. Okay, so that's how you use the concept. Now, what about if the concept is used in terms of nursing diagnosis? So, if the albumin is high, what does that mean again? The patient is dehydrated. So, what would be your nursing diagnosis? Fluid volume deficit. If the albumin is low, the client would be retaining fluids. The client would be having edema. So, it's going to be fluid volume excess. Okay, that's the way to learn. You have to reflect on concepts. You just don't have to memorize it. Okay, now, so here's actually a comparison of fluid imbalance between dehydration and fluid overload. Once again, when you have dehydration, you have high albumin. Okay, when you have fluid overload, you have low albumin. Okay, so your dehydration is characterized by weight loss, dry mouth, low blood pressure, dizziness, and fatigue. Your fluid overload is the opposite. Your patient will have weight gain, edema of the ankles and around the eyes, high blood pressure because of the retention of fluids, and breathlessness, so difficulty in breathing. Your priority nursing diagnosis for dehydration would be fluid volume deficit. For overload, we have your fluid volume excess. Okay, here's another functional concept. The characteristics of the skin depends on the degree of dehydration. Less than 5% loss, you have pale warm skin. 10% loss, very pale to cool or mottled skin. 15% loss, mottled to cyanotic but cool. So how do you assess skin turgor? Okay, you just have to pinch it and pay particular attention to whether it remains elevated after being pulled out and release. So which simply means there's gonna be poor skin turgor if it returns to normal very, very slowly. So peripheral fluid retention can be related to decreased albumin and increased serum sodium levels. So when the patient therefore develops edema, so it simply means that the client's albumin level is low or below 3.5. So the priority nursing diagnosis in a client with peripheral fluid retention is fluid volume excess or risk for impaired skin integrity. So in the care of the client with dehydration, the unlicensed assisted personnel should, take note, check and document the vital signs, assist with feeding, measure, report, and record intake, including totaling intake and output after a shift, measuring and recording height and weight, emptying and recording urinary catheter bag drainage, and report any of the following to the RN. So we need to report the presence of vomiting, which means it could worsen the dehydration, changes in appetite or eating habits, which could also worsen the dehydration, and weight loss or weight gain, because that would tell us whether the patient, we are addressing the problem properly or not. Okay, so here's a sample question. Which of the following tasks can the nurse delegate to the unlicensed assisted personnel or UAP when providing care to a client with dehydration? Select all that apply. Empty and record urinary catheter bag drainage, yes. Take the vital signs, yes. Ascertain, document the intake and output, yes. The keyword here, initiating. Always remember the initial, okay, administration of medications or initiation of intravenous therapy. That's for the RN. And then the administering intramuscular injection of antibiotic. Now, there's a danger here. If that's routine intramuscular injection, that's okay. But you have an antibiotic which could potentially lead to allergic reaction, which could be life-threatening if it causes laryngeal edema. So here, we put an X because this is a job for the RN. Okay, so we have reached again the moment for the Lucky Charm giveaway. So I'm giving away another five sets of my nursing reminder sheets and my NCLEX 311 book to 5 lucky participants today. And here is the question. Okay, here is the question. Are you ready? The question is, early on I asked about my water sign, right? My horoscope sign. So at this point in time, you've watched my living room. So I'm asking you now, what do you think is the theme of my living room? So you're given, once again, 45 seconds to answer the question through sending me an email, and those who will give the five correct answers, 5 of you will give the correct answers. The first 5 to give the correct answers will get a complete set of the Ray Gapo system learning tools. Go! The time starts now. Last 10 seconds. And 10, 9, 8, 7, 6, 5, 4, 3, 2, and 1. Okay, if you would notice the living room, we have an aquarium, windows on both end windows of the living room. That's approximately like 5 feet by 3 feet of aquarium. We have 2, so we have a lot of fishes, and then you have a lot of shells. Okay, so the theme is actually, and then the chandelier is made of teardrops. Okay, like it simulates water falling down. So the theme is actually under the sea. Okay, so those who sent me an email that says under the sea, okay, you get a pack of the Ray A. Gapo system learning tools for the NCLEX RN. So let's now move on. Here's a question. Okay, Arnold Cherry malformation leads to what condition characterized by increased CSF retention? So if you could actually also give me the correct answer to this question, I'm giving you 30 seconds to send an email now. I will consider giving you, okay, your Ray A. Gapo's system learning tools for the NCLEX RN. So give me the answer for this question. 30 seconds, go! Last 5 seconds. 5, 4, 3, 2, 1. Here's the answer. Arnold-Chiari malformation, or simply Chiari malformation, leads to what condition characterized by increased cerebrospinal fluid retention? The answer is hydrocephalus. Okay, so what's the main problem in hydrocephalus? You have accumulation of CSF, and hydrocephalus could sometimes come with neural tube defects. Remember, clients with neural tube defects like meningocele are at risk for latex allergy. Pay particular attention to that concept. And sometimes hydrocephalus could result from having meningitis. Okay? Sometimes hydrocephalus could be associated with structural defects in the brain, like Arnold-Chiari malformation, in which the lower part of the brain pushes down the spinal canal. So you have an elongation of the lower part of the brain in Arnold-Chiari malformation. Dundee-Walker syndrome is there's enlargement of the fourth ventricle because of the atresia of the passageway of CSF, meaning to say there's a narrowing or a blockage of the passageway of CSF. So this is what happens now. So in hydrocephalus, you have an enlarging head circumference. Okay, so your priority when you have a client with hydrocephalus is to measure the head circumference. Now, at birth, usually the head circumference is 33 to 35 centimeters. That's an average. Okay? Now, if the head circumference is greater than 35 centimeters, then you need to report it to the physician. Okay? Why? They need to screen the child for hydrocephalus. Now, the question is, until when do you need to monitor the head circumference? Until the child reaches the age of 3. Why? Because the first 3 years of life is the greatest time of brain growth. Okay? So that's a time for brain growth. So the first 3 years of life. Now, usually, when a child is born, as I said a while back, the head circumference is 33 to 35 centimeters, and then it increases to 38 centimeters after a month. Okay? Then, take note, at 6 months, the head circumference and the chest circumference becomes equal, and that persists until age 2. So, which means, at what age will the head and the chest circumference begin to equalize? That's 6 months until the age of 2. After 2 years old, the chest should grow larger than the head. Okay? The chest should grow larger than the head after age 2. Okay? So, Arnold-Chiari malformation and Dundee-Walker syndrome cause hydrocephalus. In Arnold-Chiari malformation, it is characterized by elongation of the cerebellum. Look, this is your normal brain. Look at the cerebellum. Okay? In Arnold-Chiari malformation, or simply Chiari malformation, look, the cerebellum enlarges and it pushes down to the spinal canal. Okay? So, in essence, it blocks the flow of CSF, so it causes hydrocephalus. Okay? Okay. That's the herniation of the cerebellum in your Arnold-Chiari malformation, or simply Chiari malformation. Dundee-Walker syndrome is characterized by atresia of the passageway of cerebrospinal fluid. So what happens is, your Dundee-Walker syndrome, okay, this is what happens in the fourth ventricle enlarges, and there's a narrowing due to the maldevelopment, okay, between the fourth and the third ventricle. So the passageway, therefore, of CSF is also obstructed. Okay, now, therefore, when you see on your test Arnold-Chiari malformation, just think about hydrocephalus. When you see in your test Dundee-Walker syndrome, just remember your hydrocephalus. Okay? So let's try answering a sample question. Which of the following signs and symptoms would you most likely find when assessing an adult client with Arnold-Chiari malformation? Now, when you have an adult client with Arnold-Chiari malformation, usually, okay, the problems in the brain would be manifested by weakness of the lower extremities, loss of sensation in the legs, and restlessness. Okay, so it's usually the leg muscles that are usually affected. That's when you have an adult client. When you have younger clients, okay, that's when the swallowing difficulty would manifest. Okay, this would be for children. Now, where the question is asking for adults, then you have your weakness of the leg muscles and loss of sensation in the legs and restlessness. Okay, now let's talk about the drug Haloperidol. Once again, I have a video that talks about your antipsychotics, okay, and how they would address the problems in schizophrenic patients. Okay, could you please visit the video? We have it on our YouTube channel. So let's talk about haloperidol. Now, your haloperidol or Haldol is a form of typical antipsychotic. Why do you have to know that it's typical antipsychotic? Because typical antipsychotics will just decrease, okay, the positive symptoms of schizophrenia, which simply means it decreases DH law. Delusions, hallucinations, looseness of association, okay, your agitation or anxiety, and word salad. So those are the positive symptoms, okay, that are decreased when a patient is taking haloperidol. And these symptoms may recur if the patient stops taking the medication. Okay, one important thing that I'd like to highlight regarding haloperidol is it may enlarge the breast and may cause nipple discharge or breast milk production. Usually this occurs in females, but in some cases it also affects males. So there's going to be nipple discharge or breast milk discharge or breast discharge, as the case may be, as described by the patient. So therefore, if the patient who's taking Haldol would tell the nurse, I'm having breast milk, okay, my nipples are secreting breast milk. So that should be interpreted as a form of a side effect of the drug. It's not a form of delusion. It's not a false belief. Your haloperidol may indeed cause nipple discharge to occur. Okay? So a schizophrenic patient on haloperidol tells the nurse that there's milk on her breast. The nurse knows that this is in a side effect of the drug. So it's not a sign of delusion, it's not a form of hallucination, but it's a side effect of the drug. Okay? So once again, I'm your mentor, Mentor Ray, saying a functional concept a day keeps your NCLEX RN fears away. So if you love this video, please don't forget to subscribe and hit the like and bell notification buttons so that you'll be notified when I add videos. I usually do that twice or thrice a week. And please do share our YouTube channel and our video for those friends of yours who are taking the NCLEX test within the month, so that they get some focus and recall concepts that they need to remember before sitting in for their NCLEX. If you do that, I'm gonna pray that you're gonna shut down the NCLEX at the minimum item of 60 and pass the test. Okay? So click the bell and subscribe notification button. So let's learn together. Send in your request to my email mentor.raygapus@gmail.com for any questions. Okay? Please stay tuned because we still have NCLEX QuickFix session number 13 after our short break.